Welcome to the Emergency Medicine Cases podcast. I'm your host, Dr. Anton Hellman, bringing you the brightest minds in emergency medicine from around the world. EM Cases is brought to you by SHREMI, the Schwartz-Reisman Emergency Medicine Institute. That's a nonprofit organization dedicated to improving EM care through high-quality research and education. The opinions expressed on this podcast are intended for information and education purposes only and should not be used to diagnose, treat, or prevent any medical condition, nor should they be used as a substitute for medical advice from a qualified practicing physician.
First, just a quick word from our sponsor, Metricade, the experts in complex physician scheduling since 2012. I've been using Metricade's incredible scheduling system for more than a decade, and it's been a game changer for me and my colleagues. Shift work comes with its challenges, but Metricade helps minimize the drawbacks by ensuring fair distribution of shifts while integrating circadian rhythm-friendly recovery time into its methodology, preserving your precious sleep so that you can perform at your best. Go to metricade.com/emcases to see how Metricade can make your scheduling fair, improve your sleep, and your performance. That's metricade.com/emcases.
This episode is brought to you by Easy Resus, the resuscitation assistant. This amazing app has drug dosing, equipment size calculation, treatment algorithms, all in under 3 clicks. Rapid access to life-saving critical info in a user-friendly interface. Try the app for free with the promo code EMCases or visit easyresus.com/EMCases. That's easyresus.com/EMCASES. Let's say you've got an older patient in your resuscitation bay. They're altered, they're cold, and they're bradycardic. Maybe the sodium's low, you're thinking sepsis, maybe environmental hypothermia, maybe even a sedative overdose. But what if you're missing the real killer? Or maybe it's the other end of the spectrum. You've got a patient who's febrile, tachycardic, who's in rapid AFib, who looks kind of septic, but isn't septic. These are the zebras that can gallop right past you if you're not tuned in to thyroid emergencies. In this 2-part EM Cases episode, with the help of Drs. George Willis and Dr. Alyssa Lewis, we'll cover both extremes, myxedema coma and thyroid storm. The master mimickers that masquerade as everything from infection to overdose to heart failure. We'll talk about the subtle bedside clues that can keep you from missing myxedema coma in the cold, slow patient, and the life-saving sequence of interventions for thyroid storm where timing is everything. You'll hear why active rewarming in myxedema can be deadly, when to give T3 in addition to T4, and why in thyroid storm you sometimes have to treat before the labs are even back. From airway pitfalls to presser choice, from mnemonics to help you remember the trigger for ordering a thyroid panel, to another mnemonic to help you remember the sequence for managing thyroid storm, we've got the pearls, pitfalls, and practical ED strategies for you. So, grab a coffee, pull up that mental checklist, and get ready. Because if you can spot and treat these endocrine crises early, you'll turn a potential ICU disaster into an ED save. So before we get into the 2 cases, we have 2 new voices to the EM Cases podcast. George Willis has spoken a couple of times in the past at the EM Cases Summit on endocrine emergencies. He's an amazing speaker. And Alyssa Lewis was recommended by intensivist Burke Tillman, who you've probably heard before on EM Cases. Any recommendation from Burke is an amazing recommendation. I just know that. So Dr. Willis, actually, first, could you just tell us a little bit about your professional background and your expertise in endocrine emergencies?
Sure. Anton, as always, it is a pleasure to be here. So thank you for having me, especially on the podcast. So my background, I am an emergency physician who works at the University of Texas Health Science Center in San Antonio. And how I got really interested in endocrine diseases, I am a child of Amal Mattu. And Amal Mattu in my faculty development fellowship said, George, you need to develop an academic niche in something. And I thought about a DKA case I had where I was an intern and they were in DKA, they were altered. And I was thinking to myself, I need to intubate this guy. And right before we got everything set up, my attending walked in the room and said, if you intubate him, you'll kill him. And I started to think about the physiology and I was like, endocrine diseases, so cool. I went back to Amal and I said, I think I'm going to do endocrine emergencies as my academic niche. And he said, perfect. Nobody wants to do endocrine. So this is the perfect opportunity for you to just jump in. And so I've taken it by the horns and have just loved breaking down endocrine diseases into the bare minimum so that people can really understand how important it is to recognize it, but also how important it is to treat it when you see it.
Great story of how you became involved in this. And yeah, almost so amazing. So that all makes sense. And Alyssa, could you tell us a little bit about your professional background and your interest in endocrine emergencies?
Yeah, for sure. So I'm an intensivist at UHN in Toronto, Canada, and I'm also a practicing internist at Mount Sinai Hospital. And, I have a general training background from GIM and critical care, and I find that endocrine emergencies are some of the most fun and gratifying to manage because if you can get the diagnosis correct from the beginning, there's oftentimes a pretty streamlined treatment pathway, and you can make a big difference in the patient's overall trajectory in a short amount of time. So happy to be here. Thanks for having me.
Yeah, absolutely. I think that's going to be a recurrent theme on these pair of podcasts is if we can just nail down the diagnosis early, we're golden. All right, let's jump into a case. A 72-year-old woman is brought in by EMS after being found minimally responsive in her apartment on a cold winter day in northern Canada. On arrival, her vitals show a temperature of 34.2 degrees Celsius, heart rate of 48 beats per minute, blood pressure of 92 on 56, and a respiratory rate of 10 with shallow breathing. She looks pale with dry skin. Her ECG shows sinus bradycardia with low voltages. Her sodium's 128. You're debating at this point between sepsis, accidental hypothermia, and endocrine causes. So let's start with you, Dr. Willis. What clinical features in this case, and actually in general, would push you towards myxedema coma or decompensated hypothyroidism?
Decompensated hypothyroidism should really be considered in any patient who presents with bradycardia, hypotension, and altered level of consciousness. So common things being common, things that we typically see in a lot of our clinical environments, patients who have altered sensorium along with hypotension should make us think sepsis, and then sepsis, and then sepsis. Sepsis until proven otherwise. But the bradycardia in this scenario should give us some pause. Most patients with sepsis are tachycardic. They have a reflex tachycardia, usually due to the hypotension coupled with the elevated temperature that we typically see in sepsis. So anytime I see a patient who's hypotensive and bradycardic with altered mental status, I certainly, as an endocrine nerd, self-described endocrine nerd, am going to think, is this the thyroid and is there a hypothyroid state going on? Additionally, the shallow breathing with bradypnea. So patients who are usually septic have deep, rapid breathing due to the lactic acidosis that's present. This bradypnea with shallow breathing kind of gives me some pause again, because if we're anchoring on that sepsis diagnosis, why is this person having shallow breathing and their respiratory rate is on the lower side? And that makes me think hypotension, bradycardia, altered mental status, bradypnea with shallow breathing. Again, is that thyroid something that should be looked into? So in this scenario, I really think we need to be looking at the thyroid.
Fantastic. You had mentioned the hypoventilation or bradypnea. I don't even think I've ever used that word, but it's a cool word. It makes sense. Bradypnea, or let's just call it a low respiratory rate.
Yep.
So this patient's respiratory rate's only 10 and they have shallow breathing. And actually we see this all the time in opioid overdoses and sedative hypnotic overdoses. So Dr. Lewis, how do you differentiate between decompensated hypothyroidism and a sedative hypnotic or opioid overdose? And why would this distinction be critical?
Yeah, it's a good question. I mean, obviously both cause hypoventilation and low GCS, but patients with decompensated hypothyroidism as the cause of their obtundation will oftentimes have concurrent findings like dry skin, delayed reflexes, hypothermia, and they won't have the pupillary abnormalities that we typically associate with something like an opioid overdose. Although I will say that other sedative hypnotics are a little bit trickier. A big red flag for me is the hypothermia. It's critical because if we don't catch this diagnosis, we're going to delay thyroxine administration and steroid therapy, which we know is life-saving.
Before we start digging more into decompensated hypothyroidism, I think we just need to get some definitions in the way. We've already mentioned the words decompensated hypothyroidism. We've mentioned myxedema coma. Dr. Willis, can you just give us some definitions of these things and anything else we need to know about severe hypothyroidism, just so that we're all on the same page?
Sure. So I personally hate the words myxedema coma for a definition for patients who have decompensated hypothyroidism, because then what ends up happening, and we all learn these in our professional schools, that myxedema coma is the diagnosis for severe hypothyroidism. And the problem with that is that we're looking for the things that are in the name. So we all learned that myxedema is usually something that presents in the pretibial area of the patient. So we start feeling the legs, feeling for that non-pitting myxedema. The problem is that myxedema can present anywhere. It can present in the thorax. It can present in the abdominal tissue. And so these patients who sometimes are a little bit on the rotund side can have some myxedema present in their abdominal wall tissue. It could present in the face. It could present in the oropharynx. And so if we're just feeling on those lower extremities for that pretibial non-pitting edema, we're going to miss that these patients may have myxedema elsewhere. The second word being coma. Most patients with severe decompensated hypothyroidism do not present in coma. They just present with some alteration in their mental status. So people assume, well, this patient's not in a coma, they're not obtunded, so they can't be in decompensated hypothyroidism or they can't be in myxedema coma, and they're not even going to send a TSH level or a thyroid function test. So we have to get away from this concept that they have to have myxedema that's present in the pretibial tissue, and they have to be in a coma, which is why I like this term decompensated hypothyroidism, which has only been present for a couple of years now, but it is a more inclusive diagnosis and definition for what we're looking for, because thyroid hormone affects many target organs. And what we really want to focus on with this diagnosis is that any end organ dysfunction as a result of hypothyroidism should be looked into for severe or decompensated hypothyroidism. So that's why I love the term. Decompensated hypothyroidism is any target organs that are showing dysfunction as a result of hypothyroidism.
All right. How about we just throw out the term myxedema coma altogether, and from now on in this podcast, just call it decompensated hypothyroidism? What do you think, Dr. Lewis?
Perfect.
Sounds great.
Okay. All right. I want to move on a little bit to when to suspect hypothyroidism in general, because I've heard all kinds of different opinions about when to order a TSH, when to order a T4, et cetera. There was actually a chart review when I was researching about this that found that almost 80% of ED patients later diagnosed with overt hypothyroidism were missed at the first encounter. So first, Dr. Lewis, why does this diagnosis keep on slipping through the cracks? And what can we do to avoid that miss and not just order a TSH on every patient we see in the emergency department?
Yeah, of course. I mean, this is a subtle presentation and there's a lot of overlap with common conditions and we miss the diagnosis. We want to think about hypothyroidism in patients who are altered, cold, and bradycardic. But in addition to those findings, we'll often also see hypotension, which is different than in the compensated state, where one of the more classic findings is diastolic hypertension. So hypotension in the decompensated state. Hypoglycemia, this is due to decreased gluconeogenesis and glycogenolysis, hyponatremia, respiratory depression, delayed deep tendon reflexes, and it can just look like sepsis without a clear source. So why does this constellation of symptoms of hypothyroidism often get missed in the emergency department, and what can we do to close the gap? It's non-specific. It can be a bit of a slow burn, and most of these symptoms are very rarely the patient's chief complaint when they're presenting to the emergency department, and can be really easy to overlook, as well as the kind of classical physical exam findings like the periorbital edema, the dried skin, delayed reflexes. These are subtle findings that if you're not thinking to look for them, you're not going to just notice them. They don't really slap you across the face. So one of the things that we can do is we can build, hypothyroid triggers into our mental checklist when we're working these patients up. So one of these red flags where I'm going to start sending off my thyroid studies is a patient with unexplained bradycardia, hypothermia, or hypotension. And other things are unexplained hypoglycemia. That patient's getting a TSH and T4, or hyponatremia. This is part of my usual workup for them. Or sepsis without a clear source is another situation where I'd order it, or unexplained new pericardial effusion or depressed ventricular function. One of the other things that I think of, I'm not an emergency room physician, but one of the reasons that I imagine it can get missed or overlooked is that the thyroid labs don't come back particularly quickly. And as a result of that, patients might actually escape the department before it's resulted. And unless your medical system has a robust way of following up late labs, this is something that can easily be missed by the time the patient leaves. Another thing is it's not part of our usual standard panels in general. So, we could consider adding something like a TSH to our general electrolyte derangement, mental checklist, or even systems bundles. So, in fact, when I was training, it was pretty standard that every time there was a psych referral or a patient with a new onset of delirium, we'd get a TSH drawn and we'd pick some people up that way. And it's definitely something that I would order routinely as part of my hyponatremia workup. Another reason why it can be missed is that the presentation may not be typical in the elderly. And even if we're thinking about thyroid or hypothyroid emergencies, sometimes in elderly populations, they might not present with the typical constellation of findings. It might be very subtle, falls, subacute cognitive decline, delirium, and you might actually be missing some of those classical findings of hypothyroid. So the bottom line here is, think about it in multi-system presentations. If there's more than two organ systems that are subtly off, for example, someone's got some neurologic derangement and cardiac derangements, or cardiac and electrolyte derangements, or anyone really with hypothermia, regardless of whether or not it's winter or there's been an environmental exposure, hypothyroid should be on the differential there. The other thing is putting your mental checklist together of when I'm going to trigger sending these labs, and then trying to create either a personal or a system safety net for how we're going to chase down and follow up those late resulting labs like a TSH and a T4.
All right, fantastic. Excellent summary there. The game changer for me there personally is, to be honest, I've never really thought carefully about a TSH in hyponatremia. I'm always just thinking about the kidneys and, should I get a urine osmolarity and is a pre-renal, is a blah, 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 blah. But that's a game changer for me for sure. So thinking about a TSH in unexplained hyponatremia. We talked about this a bit earlier, indications for ordering a TSH screen in the emergency department in general, and I want to get into that a little bit more. Myxedema coma as well as thyroid storm can both be elusive, as we've alluded to in the intro. And again, we shouldn't be ordering TSHs on every sick patient or we'll bankrupt the hospital. So Dr. Lewis, in which ED presentations should we lower our threshold to order a TSH? And what other labs should we bundle to avoid missing a thyroid emergency?
Yeah, so we should be ordering a TSH and a free T4 in patients who present with any unexplained hyperthermia or hypothermia, but thinking in the elevated thyroid categories, so unexplained fever, tachycardia, altered mentation, or hypothermia, bradycardia, hemodynamic instability, especially when sepsis or a toxidrome doesn't fully explain the clinical picture. Also for patients with nonspecific lab abnormalities like hyponatremia, unexplained hypoglycemia, even if I'm pretty sure of the diagnosis, if there's a constellation of symptoms that could be a thyroid emergency, I'll order it. And just to share one of my more memorable experiences treating a patient with thyroid toxicosis, there was a patient who frequently presented to the emergency department with crack cocaine ingestions, but he also wasn't taking his antithyroid medications regularly. And patients can have more than one problem. So in order to kind of avoid that premature closure, obviously a patient who's frequently presenting with sympathomimetic toxidromes, it can be really easy to miss this underlying cause that can present very similarly. So the bundle that I'd order alongside the TSH and the T4 is, random cortisol for sure, glucose. I also want to get a full metabolic panel to avoid missing any concurrent electrolyte or liver injury or signs of adrenal insufficiency. I also want to get a blood gas to look for any hypercapnic respiratory failure, an ECG looking for the classical findings associated with thyroid derangements, so bradycardia or low voltages, prolonged QT, bundle branch blocks, findings, as was mentioned earlier, of electrical alternans, which can suggest of pericardial effusion. And there's a helpful mnemonic that can help remind us when to order a thyroid panel called T-shirt. So T is for temperature off, so either hyper or hypothermia. S is for strange vitals, so this could be unexplained tachycardia or bradycardia. H is for heart rhythm, for new onset atrial fibrillation or flutter, especially if it's not behaving as expected to your empiric therapy. So if it's refractory or difficult to control, that's a red flag for me. I is for infection. So particularly if you're thinking infection, but you can't quite put your finger on the source of the patient's sepsis, that should be a trigger. R is for respiratory weirdness or derangement, so hypoventilation, unexplained hypercapnia, or findings of a new heart failure with respiratory distress related to that. And then the T is for 2 or more metabolic derangements, so hyponatremia, hypoglycemia, an unexplained elevated CK, elevation in your liver enzymes, or leukopenia without an obvious cause. So as I said, in addition to the TSH and the T4, we also want to get a random cortisol because it's relevant in both hyper and hyponatremic presentations. These patients oftentimes have concurrent adrenal insufficiency, and even with a borderline normal cortisol, we should be concurrently treating them for that, and we'll get into more about that, I think, later. Also, the general electrolyte panel, glucose level, liver panel, including AST, ALT, alkaline phosphatase, and bilirubin, which not only is it helpful for diagnosing the end organ dysfunction, but is helping to guide our therapeutic choices, particularly in patients with hyperthyroidism and thyroid storm. Very important to know what their baseline liver function is like. CK, blood gases, cardiac enzymes, and BNP, which is helpful both for diagnosing the cardiac manifestations, but also for helping guide our therapeutic choices, particularly our beta blocker usage when we're thinking about symptomatically managing a patient with hyperthyroid emergencies or thyroid storm. We really want to get a handle on their underlying cardiac status and any features that they might have of congestive heart failure, specifically with poor ejection fraction. So I'd also bundle POCUS in with their cardiac enzymes and BNP. And then for every single patient coming in with a thyroid emergency, they absolutely need an infectious workup. Infection is such a common trigger in both hypothyroid decompensations as well as hyperthyroid emergencies. You really do not want to miss the sepsis while we're focusing on treating their thyroid gland.
Well, that's a key point there. So if you're thinking thyroid emergency, cover for sepsis, no matter what in the emerge, I think is a great take-home point. I want to talk a little bit more about thyroid testing. We've got our TSH as a general screen, the T4, and then there's the T3. And to be honest, I'm not quite sure when to order a T3, when to order a T4, when to just order a TSH. Could you just review for us, without going too much into the weeds on the internist nerdiness, when should we consider ordering all three? When should we just order a TSH? And when should we order a TSH and a T4? Like, what's the difference?
It's a really good question. The T3 is the metabolically active form of the hormone. The T4 is a prohormone. I bundle TSH and T4 in my mind together because this will help you guide your diagnosis based on those two values alone. T3, it tends to be depressed in critical illness, so non-thyroidal illnesses and sick euthyroid syndrome. The times where it can be helpful to add it on, where it'll add to your kind of diagnostic reasoning, is if you think that the patient has a very rare situation where they're presenting as thyrotoxic, but your T4 is normal. There can be situations of an isolated T3 thyrotoxicosis. So if your labs are normal, but you still maintain a very high suspicion that your patient is thyrotoxic, it can be helpful there. And then the other situation is if you suspect that your patient has had an isolated T3 ingestion. So liothyronine, which is a medication that we oftentimes use in patients who are critically ill with decompensated hypothyroidism, if you think that they've had an isolated ingestion of that medication, which is also I believe, called Cytomel that can be helpful in that situation. But to be perfectly honest, the bottom line is if you're ordering the TSH, you should be ordering the T4.
If you're thinking thyroid, order TSH and T4. Really, the only times you'd order a T3 is if you've got a thyrotoxic patient with a normal T4 or if they've overdosed on T3. And now a message from one of our sponsors. Are you an emergency physician looking for an exciting opportunity? Cornwall Hospital is hiring motivated ER docs to join their dynamic team. With over 50,000 visits a year, you'll see a wide variety of pathologies in a fast-paced, supportive environment. Your colleagues and consultants are always ready and willing to back you up. Cornwall, Ontario is a hidden gem on the St. Lawrence River, offering waterfront access, outdoor activities, and a small city charm. All within an hour's drive from Ottawa and Montreal. Join their family at Cornwall Community Hospital, and once you're there, you'll never look back. For more information, please visit www.cornwallhospital.ca and click on Join Our Team, Physician Recruitment, or call 613-938-4240, extension 2227. So talking about TSH levels and T4 levels, there are hypothyroid scores out there. There's I'm probably mispronouncing this, there's the Popovenyuk score and there's the Cheong tool that both aim to identify decompensated hypothyroidism, or what they call myxedema coma, which we're not allowed to say anymore. So they look at things like vital signs, GCS, hypoglycemia, hyponatremia, precipitating event, and like I said, TSH and T4 levels. So Dr. Willis, should we use these scores or these tools to diagnose decompensated hypothyroidism in the ED, or is the diagnosis more based on clinical gestalt? What do you think is the use of these tools clinically?
So these scoring systems are difficult to use. First, most of the scoring systems for thyroid disease were derived due to the lack of availability of diagnostic thyroid function tests in the emergency department. I remember when I was a resident and I worked at a large tertiary care center in Baltimore, TSH was readily available, but that's not common at that time. As a matter of fact, I remember lecturing at some national conferences and international conferences on thyroid disease in the emergency department. And I would say, just get a TSH. And people would just laugh at me. And they say, that's a send out lab for us. And in some places, it wouldn't be back for a week before they actually got those values. And so these scores use clinical data and diagnostic data that's readily and rapidly available in the emergency department. And they were derived to give the clinical rationale to treat thyroid disease in the absence of those tests. So the Birch-Wartowski score, which came out in the 1990s, which was specifically for thyroid storm, and then the Akamizu, or the Japanese Thyroid Association score, which came out in 2012, again for thyroid storm. But we didn't really have a scoring system for decompensated hypothyroidism until this Popovenyuk score came out, which is also called the Myxedema Coma Diagnostic Score, which came out in 2014, and then the Cheong tool, which was put out by Cheong et al. In 2015, a year later. So the Popovenyuk score looks very similar to the Birch-Wartowski score. They include the degree of vital sign abnormality. So the lower the temperature, the higher the score. The lower the bradycardia, the higher the score. The lower the bradypnea, the higher the score. They also look at some physical exam findings or historical elements, such as presence of constipation versus an ileus, which gives you a higher score. The lower level of consciousness, again, gives you a higher score. And then some objective ancillary data, such as presence of pleural effusions on the chest X-ray, presence of hyponatremia, presence of hypoglycemia, all elevate the score. So those scoring systems give you a score, and it's either highly suggestive of myxedema coma, at risk or possible myxedema coma, and unlikely for myxedema coma. The Cheong tool looks very similar to the Japanese Thyroid Association score in that they use what I think are a little bit more clinically relevant because they use extremes of vital signs. And so they say if the bradycardia is profound, then that gives them a positive score. And they actually also use the thyroid function test values in their scoring system, very similar to the Japanese Thyroid Association score. And so this one's supposed to be easier to use than the Birch-Wartowski score and the Popovenyuk score. The problem with both of the scoring systems for decompensated hypothyroidism is twofold. The first one being They were both performed in a very small number of patients based on retrospective data. And then secondly, again, unlike the Birch-Rogowski score and the Japanese Thyroid Association score, neither of these scoring tools have been externally validated. And so the problem with these scoring systems, again, is they're not really useful at this point in time because thyroid function tests are much more readily available in a lot of hospitals. And so these scoring systems, I think, are starting to get less and less used, and I think are used more as an adjunct to our clinical decision making as opposed to the absolutes that we had to do when thyroid function tests were much less available.
Brilliant. Is it safe to say that, like most scores, good to know the various elements, but they shouldn't really replace our clinical judgment?
Absolutely, 100%.
All right. Yeah, I think you can say that about pretty much every score we use in emergency medicine. An easy conclusion to make. We've touched a little bit on low voltages on ECG, on pericardial effusions, on heart failure that we sometimes see in decompensated hypothyroidism. That brings up POCUS. So, Dr. Willis, what are the key POCUS findings in decompensated hypothyroidism, and how are those going to influence your resuscitation?
So when I get a hypotensive patient who comes into the emergency department setting for me, I bring a friend. I bring my POCUS. I bring my ultrasound with me because I want to find where the etiology of this hypotension is. So if it's a patient with decompensated hypothyroidism, as we discussed a little bit ago, 80% of these patients have some type of pericardial effusion. So commonly, you're going to see a pericardial effusion in patients who come in with decompensated hypothyroidism, and they may even have tamponade physiology. So you may see some of that diastolic collapse on the outside. You're going to obviously see your swinging heart in that anechoic area. So in those circumstances, you're certainly going to be seeing that pericardial effusion. But if you are facile with ultrasound, and so you may see some element of low EF and low cardiac output with patients who come in with decompensated hypothyroidism that looks like a decompensated CHF patient. This can kind of help in terms of how I'm going to resuscitate these patients. If they have a low EF, I'm very cautious with my IV fluids. 2 liters bolus kind of reflexively, which is what a lot of emergency physicians do when they don't use ultrasound, is they see that hypotension and they think, oh, this patient's septic. I need to give this patient a lot of IV fluids in a very small amount of time. And that can certainly be harmful in this patient population. So if I see they have a low EF, I'm next going to look at what their IVC looks like. If their IVC is full and they have a low EF, that may actually push me to holding any IV fluids and starting with pressors, which may not work in your decompensated hypothyroidism, but it may induce me to think maybe we need to get some thyroid hormone on board, especially if I'm very suspicious that this person may have decompensated hypothyroidism, so that my vasopressors will work. But if I'm looking at that IVC and it looks full, the pressors are going, and I think that they may need a little bit of IV fluids, I don't start with that 2 liters. I'm going to start with a much smaller bolus, maybe 100 mLs, maybe 250 mLs. If their IVC is empty, then I can go up a little bit more. But remembering if that EF is low, I can fill up that EF really, really quickly. So I might use 250 to 500 mLs, but I'm not just telling the nurses, hey, let's give this patient a liter bolus right off the bat. Now, if their IVC is empty, and they have a large pericardial effusion with tamponade physiology, that's a person who I may consider doing a pericardiocentesis on. That hypotension may be a result of tamponade, and they may benefit from a even small or a what I call controlled pericardial drainage, where I'm pulling off 10 mLs, 15 mLs, 20 mLs to see what their hemodynamics do. And if their hemodynamics improve, then they may need some more operative intervention in the long run. And I may give them some fluids as well to help with their hemodynamics prior to them getting to that state as well. I'm also looking at the lungs. In the lungs, I'm looking for B lines or any signs of volume overload. But the other thing that you may see in decompensated hypothyroidism is you may see patients who have developed pleural effusions as a result of their disease. Most of the time, these patients don't get significant pleural effusions. So you're not going to see a chest x-ray in these patients and they're going to have, a half or 3/4 of their lung full of effusion. But you may see a small to moderate size effusion, but you're certainly going to catch this on your ultrasound more than you are on your chest x-ray. If there's large effusions or moderate size effusions where the patient's that bradypnea and that shallow breathing may be a result of the pleural effusions that are present, if I have to intubate this patient in the long run, their ventilation may be affected as a result of these pleural effusions. And so I may need to adjust my ventilator settings as a result of these large or moderate sized pleural effusions in this scenario. And I may even need to do a thoracentesis in this patient to help with their respiratory status, obviously depending on some other factors. Are they profoundly hypoxic and I can't oxygenate them despite maximizing their oxygenation? And it's simply because they have too much of a pleural effusion. I may need to do a thoracentesis in this scenario as well. So all in all, the big things that I'm looking at with POCUS are, I'm looking, is there a pericardial effusion? Is there any sign that the patient's developing tamponade or already in tamponade? I'm looking at their overall EF, and that's going to help me in terms of how much volume I'm going to get them versus starting these patients early on vasopressors. Does this patient need a pericardiocentesis? Looking at the IVC, does this patient have tamponade? They may need a pericardiocentesis. Looking for B lines, looking for pleural effusions to see what I'm going to do next. And then lastly, every once in a while, I'll take a look at the abdomen, especially if they have a large rotund abdomen with the rest of their trunk not showing a significant amount of increase in size. I'm looking for signs that, does this patient have ascites? Could that be compromising their respiratory status as well? And if they don't have a pleural effusion, if their respiratory status is shallow and breathing, maybe it's because of a significant amount of abdominal fluid. And in that scenario, I may need to do a paracentesis to help get some of that fluid off to improve their respiratory status.
Wow, who would have thunk that POCUS would be so useful in decompensated hypothyroidism? We've got this metabolic abnormality, and here we are using POCUS. Amazing. Let's say we've diagnosed decompensated hypothyroidism, but as we've mentioned, it's important to search and treat the precipitant of the decompensated hypothyroidism. So Dr. Lewis, first, why is it important to find the precipitant, and what are the common precipitants we should be on the lookout for and treat in the ED whenever possible?
This is so important because honestly, it's challenging enough finding the decompensated hypothyroidism for all the reasons that we discussed before, but there's always something that's tipped the patient over. It's a slow burn of a diagnosis, but then something happened that made them present today. And treating the patient with thyroxine without discovering and treating the trigger is like bailing the water while the hole in the boat stays open. So the hormonal derangement started somewhere, and if you don't plug that leak, the patient can spiral right back into crisis despite thyroid replacement. And more importantly, they might die of their trigger while we're focusing on the thyroid. So the big ones, if you take one thing away, it's infection, 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 infection. This is by far the most common trigger for decompensated hypothyroidism. And in these patients, everyone where you're suspecting decompensated hypothyroidism should have cultures drawn. And if they're sick, they need empiric broad spectrum antibiotics while awaiting the culture results and a detailed examination and workup for a source of infection. There's several other triggers that can tip patients over, things like MI, stroke, bleeding, recent surgery, introduction of a new antithyroid medication, obviously missing their thyroid supplementation. So this is something that we're going to need to ask explicitly about access to their medications, any recent changes in their doses, any missed refills. And I'd also recommend asking about the use of naturopathic or complementary alternatives. There's a lot of patients who are coming in with preference towards desiccated thyroid hormone, which might be more difficult to dose accurately or might be less regulated than the pharmaceutical alternatives. There's also medications with thyroid suppressive effects that we should ask specifically about. For example, new use of amiodarone, lithium, opioids, and not just as a trigger for their presentation, but they can have exaggerated responses due to their metabolic slowing and the effect of hypothyroid states on clearance of medications. Other things like SSRIs, antipsychotics, exposure to iodinated contrast medias that can suppress the hypothalamic pituitary thyroid axis. And so really, the main thing is think of infection, search it out, treat it, ask if they're taking their underlying or their chronic home thyroid medications, and then look for some of the other physiological stressors.
Excellent. All right. Co-treat and co-search for infection, treat for sepsis is a big one because that's going to be like half of the patient's triggers. We really need to dig into their medications and see what's going on there and really think about the trigger and try and treat it in the emergency department because they'll do better if we can identify and treat that precipitant early.
100%.
Let's just do a quick summary here. So what we do next time you've got that cold, slow patient in the ED, first, don't just think sepsis, hypothermia, or tox. Make hypothyroidism part of your sort of reflex differential when you see bradycardia, hypothermia, and hypotension, especially if there's hyponatremia or hypoglycemia that's unexplained. Second, use the bedside clues, dry core skin, periorbital puffiness, delayed reflex relaxation. If they're hypothermic without shivering, or their respiratory rate is in the single digits without pinpoint pupils, your thyroid radar should be lit up. The scores for myxedema coma are worth looking at to remind us of some of the clues and maybe help us decide whether or not to treat on spec, but their accuracy is not great based on very tiny studies, and your clinical gestalt after listening to this podcast is probably going to be better. Third, grab your ultrasound. A small pericardial effusion or a globally sluggy low output heart in a bradycardic hypothermic patient is a big red flag for decompensated hypothyroidism. And finally, I love that T-shirt mnemonic to trigger thyroid testing when the picture doesn't fit and bundle it with cortisol and your metabolic panel. You do these things and hopefully you'll catch decompensated hypothyroidism before it catches you off guard.
Let's take a little break to hear from one of our sponsors, Metricaid, the experts in complex physician scheduling since 2012. Metricaid's expert schedulers are their secret sauce. These people truly understand the complexities of physician scheduling. They empower us by providing the tools we need to manage our teams efficiently. At the same time, they give physicians more freedom to share their workflow preferences, so schedules aren't just fair, they're actually workable. Metricaid's system is built to make your schedule work for you. They take the stress out of shift planning so that you can focus on what matters most. Go to metricaid.com/emcases to learn more about how smarter scheduling can work for you. That's metricaid, one word, .com/EMCASES.
All right, let's move on to Dr. Willis. You touched on this a little bit when you talked about POCUS, but for our initial resuscitation, I want to start off with the airway. Airway in severe hypothyroidism is not straightforward. So, Dr. Willis, what are the key considerations before intubating a decompensated hypothyroid patient, and why can RSI sometimes lead us to cardiovascular collapse?
So this is a really important topic to discuss, and it's one of my favorite things to talk about when I talk about decompensated hypothyroidism, because I think that emergency physicians, we get a little cocky when it comes to the airway, because we oftentimes think of the airway as this is our arena. This is the thing that we know how to do very well. And so there will be many times where I will be intubating a patient and I'll have the medical student either come next to me. I've even let medical students intubate before. I've certainly let my residents intubate. Decompensated hypothyroidism is not the circumstance where I am just allowing anybody to willy-nilly intubate. This is the time where I know that if I need to intubate this patient, my anal sphincter is very, very, very tight. You can't even get a needle in between my anal sphincter. It is that tight. More often than not, these patients will require intubation because these patients oftentimes are hypoventilating, oftentimes are hypo-oxygenating, and they're oftentimes worsening their acid-base status. And this is not something that oftentimes repairs quickly, despite the fact that we may get thyroid hormone involved very early. These patients don't just magically bounce back and say, I'm back to normal. It takes a long time for this recovery to occur. So they also may not be protecting their airway due to profound altered sensorium. However, these patients are not going to be easy, as we've discussed before, in most circumstances, because they don't want you to intubate them. Physiologically, they're going to make this a very dangerous intubation. So I always say if a patient has decompensated hypothyroidism, it should be the most experienced intubator in the room. And here's physiologically why. Cardiovascularly, they are not maximized hemodynamically. A lot of clinicians who are getting ready to intubate, the first thing that they look at to see if a patient's at higher risk for developing circulatory collapse peri-intubation is the shock index. So that heart rate over the systolic blood pressure. Well, if you use the shock index in patients with decompensated hypothyroidism, you might be falsely reassured because their heart rate is low and their systolic blood pressure is not going to be so profoundly depressed that you're going to think to yourself, oh, this patient's shock index is enough for me to be able to intubate this patient. So let me assure you, they are not optimized hemodynamically for intubation. That pericardial effusion that's going to be present is going to certainly harm your hemodynamics. Certainly, if you induce a whole bunch of significant positive intrathoracic pressure, that pericardial effusion is going to significantly cause preload collapse, circulatory collapse, and cause that patient to have peri-intubation cardiac arrest. Similarly, their low cardiac output is going to hurt their hemodynamics. So despite the fact that you might have a very good or a reassuring systolic blood pressure, that EF is going to certainly harm you when you start to harm the hemodynamics if you just start throwing any induction agent around thinking that this is going to be a standard intubation. Their preload is going to be low. So IV fluids certainly is going to be helpful. But again, we have to be careful about how much IV fluids that we're giving these patients with this low EF. So induction agents that compromise hemodynamics are largely going to lead to a circulatory collapse and arrest. So make sure you have your push dose pressors around for circulatory and hemodynamics. Respiratorily, these patients, I don't even know if that's a word. I think I just made that up.
Great word.
Respiratorily, they are not going to pre-oxygenate well because of their low respiratory rate, because of their shallow breathing, and because they do not have a significant amount of oxygen reserve. So you will induce and paralyze these patients. And where we usually have 45 seconds to maybe a minute and a half to intubate these patients before we may see hypoxia starting to develop, these patients, we have mere seconds before they start to have hypoxia start to show up, where you have that reassuring sound in your ear, beep, 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 while the patient's getting intubated. These patients are more like beep, beep, beep. And you look at the oxygen saturation and it's 20. Along with their heart rate, and they're getting ready to circulatory collapse. So from a respiratory perspective, because of their bradypnea, because of their shallow breathing, in addition to their airway is smaller. These patients oftentimes have macroglossia, so their tongue is bigger, as well as the fact that they may have myxedema of the airway. So you look in that posterior pharynx, and I know that people are not going to be able to see this wonderful picture that I have of a patient who I told we may have to intubate, but I'll show certainly these two. But you can see that posterior pharynx looks super awesome. And so to describe what we see here is the tonsillar pillars. This patient did not have a sore throat, but the tonsillar pillars are so edematous that they're actually kissing. So they look like kissing tonsils. And it was a patient in severely decompensated hypothyroidism. So sticking a laryngoscope in the back of his throat is not going to make your airway magically appear. And the arytenoids can be affected, the vocal cords can be affected. And so in this scenario, that airway is going to be smaller. Not to mention the fact that some patients with decompensated hypothyroidism may have the presence of a goiter if their decompensated hypothyroidism is due to Hashimoto's thyroiditis. And so that goiter, you might get the ET tube in to right in between the vocal cords and then get stuck on that goiter and not be able to advance it further into the airway. So in patients who I'm intubating who have decompensated hypothyroidism, I kind of have a mental checklist. And that's first and foremost, one, it's probably going to be me or a very good senior resident who's intubating this patient. In this scenario, I'm going to use a smaller ET tube than usual. So usually a half size smaller than what I usually will use. I always have my bougie, and that's for any intubation. I have my bougie at the bedside, if not using it as my stylet to kind of help with the intubation. But you're not going to be able to see everything in this scenario, so I will use video laryngoscopy and sometimes even use the hyperangulated blade to help me in this scenario. For my induction agents, I use ketamine or etomidate. More commonly, I'm going to use ketamine because I love ketamine. What emergency physician doesn't love ketamine? And then rocuronium, but I'm typically going to use my paralytics only once the blood pressure gets high enough to where I'm going to be able to use it with or without vasopressors on board. And oftentimes I'm going to have vasopressors on board as long as they are working, which we know sometimes doesn't happen with decompensated hypothyroidism until we get thyroid hormone on board. So those are kind of my big pearls when patients with decompensated hypothyroidism need to be intubated, is to make sure you're doing it the right way. It's not your standard intubation.
Okay, so for both anatomical and physiological reasons, these patients can be very challenging. We should probably have a pretty high threshold to intubate these patients across the board.
One of the things that I would tweak a little bit is, if they do have a pericardial effusion and we are concerned about, evolving tamponade physiology, I'd be really careful about maneuvers that might drop their preload in that setting. So in that setting, I would limit the PEEP that I'm using, putting it on the lower side. And, we don't generally do recruitment maneuvers for ICU all-comers, but this is a situation where I'd particularly be cautious, especially if they've got a pericardial effusion. And beyond that, I just, keep an eye on their gases, as we always do once the patient comes upstairs. You can pick whatever initial ventilator settings is reasonable or the patient tolerates from a hemodynamic perspective and make adjustments from there. You don't have to get it perfect, within the first 30 seconds of having the tube in. I'm much more interested in having them not arrest due to, severe acidosis during their apneic period when you're putting the tube in, or not having a cardiac arrest because of a failed airway attempt or a hemodynamic effect of a pericardial effusion. So shouldn't be too difficult once you've already done the hard part.
Okay, fair enough. So in terms of ventilation strategies, for your run-of-the-mill decompensated hypothyroid patient, you can just use your usual ventilation settings. However, be really careful if they have a sizable pericardial effusion. If they're heading towards tamponade physiology, that's the patient who you want to be really careful about. So that's all we're going to talk about airway. I want to talk about managing the bradycardia. So emergency doctors' reflex when they see bradycardia is sometimes to pull out some atropine or at least consider it. Every time I've talked about atropine on emergency medicine cases, the answer is usually don't use it. So I'm not really sure how atropine is like the number one recommendation on the ACLS guidelines. But anyhow, that being said, in this situation, for the severely bradycardic hypothyroid patient, should we consider reaching for atropine or something else? What do we do with the bradycardia, Dr. Lewis?
Honestly, your patient's crashing in front of you. You can try it. It just might not work. This is a hormonally mediated bradycardia. And so our usual kind of ACLS algorithm drugs might be less efficacious. We've really got to get them on their thyroid replacement therapy and stress dose them with steroids. The chronotropes just might not work. I kind of think of it like using Ventolin to treat a wheeze in a patient with anaphylaxis. Sure, it might bronchodilate them a little bit, but really what we want in that situation is epinephrine to treat the anaphylaxis. In this situation, maybe a bit of atropine, maybe a bit of epi, something with chronotropy, but you've really got to fix the underlying problem.
Great analogy. I love that. All right, let's talk a little bit about hemodynamic support. So we've talked about bradycardia. Let's talk about the blood pressure. So when there's hypotension and it's not responding to fluids in the patient with decompensated hypothyroidism, what's your vasopressor of choice? Why? When do you start it? Dr. Lewis?
It's good old-fashioned norepinephrine. It's first line. You're almost never wrong if you're reaching for it, but just remember, the responsiveness to it might be blunted until their hormones have been adequately replaced. It's good because it'll help with peripheral vascular resistance, kind of clamping down those arteries. And there's a little bit of an ionotropic, marginal chronotropic effect as well. When do I start it? I have a pretty low threshold to start it, generally speaking. Aside from the stress dose steroids, which are usually readily available in the emergency department quite quickly, it can take a little bit of time to get their thyroid hormone replacement and do your kind of drug dose calculation, make the decision to start it. So if my patient's MAP is below 65, I'll usually start it if they're refractory to their judicious fluid bolus quite early. The other thing that I want to say is you can use vasopressin in this situation. It's usually an add-on if a patient isn't responding to their norepinephrine. Remember, this can worsen their hyponatremia if it's present, just based on the hormonal effect of the vasopressin, something to keep in mind if they're severely hyponatremic. And then, you could try epinephrine if there's a concurrent cardiogenic shock component. Other ionotropes tend to cause worse peripheral resistance and can drop after loads. So I would wait until they were more resuscitated before doing anything like a dobutamine or a milrinone. And so bottom line, good old-fashioned norepinephrine. Do it if you need to resuscitate them while you're getting your thyroid hormones on board, but do not delay stress dosing them and giving them their thyroid replacement.
Right. So don't be surprised if after you give your thyroid meds and your steroids that they don't need the norepi anymore.
Totally. It should come down. We expect it to come down. And if it's not coming down, we should be looking for another etiology if there's shock.
Fantastic. All right. Let's just summarize here a bit of the initial resuscitation here. So first, for the airway, anticipate a big, boggy tongue, glottic edema, and a heart that's still kind of running on fumes. Preload them with gentle fluid bolus. Consider having norepinephrine running before you push any paralytics if you need to intubate them. We're going to have a high threshold to intubate them in the first place. You'll probably be using ketamine or etomidate for an induction. You might want to go with a smaller ET tube and get ready for a backup plan for the airway. Second, in terms of ventilation strategies, for the run-of-the-mill mixed edema coma patient, you can use just your run-of-the-mill ventilation strategies, but be cognizant of a big pericardial effusion because you'll have to change that if they do have a really big pericardial effusion. Third, for bradycardia, atropine's probably not going to fix their bradycardia. You really want to get that treatment in with the thyroid hormone and the steroids, not chronotropes. And for hypotension, you're going with your good old norepinephrine. You can add in vasopressin, but be aware that it can cause hyponatremia. If there's a cardiogenic shock component, then epinephrine's a reasonable choice to add as well. And finally, don't forget your antibiotics that we need to be treating for sepsis as well. And the earlier we get those antibiotics in, probably the better. And now a word from one of our sponsors, Paratus, the all-new emergency assistant. Paratus combines everything you loved about Easy Recess with powerful upgrades, just-in-time procedural guidance, stress-proof organization, and Atoms, the intelligent assistant that helps you find exactly what you need. Whether you're in the ER, on transport, or in the field, Paratus keeps you ready for anything. Learn more and start your free trial today at paratusmedical.com/emcases. That's PARATUS medical.com/emcases. We've talked about initial resuscitation. I want to move on to the medications you're going to give for the actual hypothyroidism. And one of the big pitfalls in thyroid emergencies is not giving what we call those stress dose steroids. So let's actually start with the steroids. Dr. Lewis, why is it so critical to give stress dose steroids up front in both thyrotoxicosis and decompensated hypothyroidism, even before the labs come back?
So there's a lot of different reasons for this. The most important thing is to remember to give it. But when patients present with decompensated hypothyroidism, they oftentimes have concurrent adrenal insufficiency. And even if it's marginal, even if they've got like a low normal, technically normal random cortisol level, we still need to treat them for it. And the reason for this in a decompensated hypothyroidism situation is because when you start supplementing them with levothyroxine, what happens is their metabolism picks up and it increases their cortisol clearance, which can unmask or even precipitate adrenal crisis. So the dosage that we usually use in a hypothyroid patient is 100 milligrams IV Q8 hours. And you should do that actually before giving them their IV levothyroxine. But one of the things that we talked about earlier in the podcast is mental grouping. So we want to be mentally grouping our thyroid and our stress dose steroids together for either thyroid emergency. Don't forget the steroids.
All right. If you're thinking thyroid, think steroid. Excellent. That kind of rhymes.
I love it.
Okay, let's talk about the actual thyroid medication now, so levothyroxine. Dr. Willis, how do you choose an appropriate initial dose of IV levothyroxine, and then how do you titrate it from there?
Sure. So thyroxine has a very variable range of medication recommendations when you look at the books and the guidelines, and they say anywhere between 200 and 500 micrograms of IV thyroxine is indicated for patients with decompensated hypothyroidism. That's a big range to choose from. So in patients who come in with decompensated hypothyroidism who are certainly hemodynamically compromised, it's better to get the levothyroxine on the thyroxine on board early. And I usually tend to hit them a little bit on the harder side with the higher dose, the 500 micrograms. When they come in and they have either they're elderly patients or they have a significant cardiac history, because thyroxine, although it's a low risk, much more than liothyronine or T3, there is a small risk that these patients can have a higher risk of developing either ischemia from the coronaries of getting affected by the presence of the thyroid hormone where there was none, or they can have a higher risk of developing an arrhythmia as a result of their stunned myocardium that they've had in the past. Again, the risk is very small, but I tend to do it a little bit on the lower side in that patient population. So those are the two big patient populations I tend to stay on the lower side.
Great. I think that's perfectly exactly what we need to know about levothyroxine for the emergency department. Sometimes we have a patient who doesn't respond so well to the levothyroxine. They're like critically ill, really sick. Hopefully by this time, they're up in the unit and Dr. Lewis is taking care of them by now, and we don't have to really worry. But let's say they're stuck in the emergency department. What's the role for adding T3? So my understanding is that, you've given your T4, you've given your levothyroxine, and then sometimes you want to add leothyronine, which is T3. But I understand this also has some potential cardiac complications. Dr. Lewis, could you just give us the lowdown just in case we need to be thinking about giving T3? What do we need to know about it?
Yeah, for sure. So this is an area where the evidence is admittedly a lot thinner, but we can consider adding it in patients with severe symptoms or persistent symptoms despite their levothyroxine. And we would be selecting patients who, are profoundly comatose, in respiratory failure, not improving, within 6 to 8 hours after starting their IV levothyroxine, those with refractory shock despite steroids, pressors, and T4 supplementation. We know that they've got some sort of underlying deficit that's going to impair their peripheral conversion of T4 to T3. So, for example, if the patient is hypothyroid in the context of an amiodarone usage, or if they are severely septic, they've got underlying end organ failures, underlying cirrhosis or renal failure, that's another situation where you might want to add it. And patients who have a central or a secondary cause of their hypothyroidism, where we know that they have low baseline T3 supplementation, they might benefit from additional, repletion. So when we're thinking about giving it, In addition to those, severely ill patients or patients who are having a difficult time responding to therapy or just not turning the corner as quickly as we'd like them to, we really do have to be careful because this is just the straight metabolically active version of the hormone, particularly in patients with underlying coronary disease and those who have underlying concurrent arrhythmias, both of which can be tipped over. And also the elderly. So you would want to pick doses on the lower range and keep them obviously in a highly monitored setting and be ready to respond to any complications that they might have from the medication.
All right. Good to know about T3. I'm calling you, Alyssa, if I ever have a patient that gets to that point where they're going to need T3.
And I'm calling an endocrinologist for advice. So we each phone a friend.
So we've talked about initial resuscitation, we've talked about airway, we've talked about how to manage bradycardia, we've talked about how to manage hypotension, we've talked about steroids, we've talked about levothyroxine, and we've talked about T3. The one thing we haven't talked about yet is rewarming, and I had hinted to this at the beginning that we do not want to be doing active rewarming, we want to do passive rewarming. So Dr. Willis, how should we be rewarming the patient who presents, say, with a temperature of 33.5 degrees Celsius with decompensated hypothyroidism?
Sure. So it's almost a reflex when we see these temperatures that are 34, 33, 32, that we're saying to our nurses, go get a whole bunch of warm blankets, go get a bear hugger, let's get warm IV fluids, especially when they're exposed. And we've talked about these patients who come in with decompensated hypothyroidism presenting in the wintertime. And so when they come in exposed potentially from the outside elements and they're very hypothermic, we reflexively just start being very aggressive. And in decompensated hypothyroidism, that's actually potential for significant harm. The reason why is because these patients oftentimes are maximally vasodilated. They have vasodilated to the nth degree, and then we're going to throw a whole bunch of warm IV fluids and bear huggers and aggressive active rewarming that's going to make them even more vasodilate and can certainly predispose these patients to developing circulatory collapse. And so we have to be really careful with these patients specifically. But the primary way that we're going to warm these patients is going to be by, as Dr. Lewis elaborated on, getting them their thyroid hormone involved as quickly as possible. So if we're going to do rewarming, and certainly patients who come in, as we know, hypothermia can predispose patients to developing significant ventricular dysrhythmias. They can develop altered mental status. Certainly that bradypnea and shallow breathing can be a result of the hypothermia. So we know that warming them is probably going to make a little bit of their symptomology improved. They would rather us do passive rewarming in this scenario. And so what a lot of people recommend is increasing the temperature in the room, not necessarily getting aggressive with the bear hugger, but just turning the temperature up in the room. Doing something called the sandwich technique, where I personally don't use warm blankets for these patients who have decompensated hypothyroidism with hypothermia. I just put regular blankets on them. And as the ambient temperature of their body transfers into the blanket, I am quick to remove that blanket as it cools down to put another blanket on top of them that's normal body temperature. Using warm IV fluids is not necessarily going to be significantly harmful, but again, we're not giving these patients lots of IV fluids, so that's not going to be my primary source of warming in this scenario anyway. So typically, the big thing that I'm just going to use is normal room temperature blankets for these patients, and then just increasing the temperature in the room as a form of passive rewarming. As a result, what ends up happening as soon as we get the thyroid hormone involved, they will start to have an increase in their body temperature as they start to make more beta receptors, which the thyroid hormone helps to stimulate the production of, and subsequently they end up getting an increase in their body temperature ambiently on their own. So just avoid kind of your rule of thumb here. Avoid being super aggressive with these patients, especially when they're already hypotensive. You certainly don't want to cause circulatory collapse. Just do passive rewarming as opposed to being aggressive with active rewarming.
All right. Yeah, that kind of highlights the importance of getting the diagnosis right from the start, because For the environmental hypothermic patient, the first thing we reach for is active rewarming, but active rewarming, as you've been saying, can actually kill hypothyroid patients. So it's all, again, about passive rewarming in these decompensated hypothyroidism patients. Okay, great. We're reaching the last lap here on the podcast. Any other last pearls or pitfalls when it comes to hypothyroidism? Dr. Lewis, let's start with you.
Yeah, I would say one of the things that we want to do is maintain a very high index of clinical suspicion, even if there's a potential alternative diagnosis for the patient's presentation, or you're thinking along the lines of something that is more likely in the emergency room. Don't forget to think about the thyroid. So especially in the elderly patients who are presenting with altered mental status, anyone with hypothermia, it's a common mimicker of sepsis, certain overdoses. So don't forget to send it. And also don't forget to treat for concurrent adrenal insufficiency, the random cortisol. Even if it's low normal, you still need to stress dose the patient. And always remember to check for infection and treat empirically while we're waiting for the results. This can be a real killer here. And if we are focused on treating the thyroid rather than treating their sepsis, the patient's going to die regardless. So don't forget that.
Those are some really great take-home points. George, I don't know if you can come up with, I don't know, you can't really beat that. Let's see. I don't know. I'm giving you a little challenge there, George. Any other last key pearls or pitfalls?
No, I have lots. Hold my beer. Here we go. So, all of them are very pertinent, and she had some great ones, which I think are super pertinent. Mine are going to focus primarily on just the ABCs, which are your airway. Not going to be easy. Should not be something that you're just kind of dusting your shoulders off thinking, oh, this is going to be a simple, easy thing. This is going to be a difficult airway, and be prepared for a difficult airway. When it comes to the resuscitation of the patient, these patients are hypotensive. Don't think, let's just throw a whole bunch of IV fluids on board. Bring your POCUS with you. Use your ultrasound to help guide your resuscitation. Patients may need pressors early, and in this scenario, they oftentimes do, but those vasopressors may not work. You may have to get the thyroid hormone in before vasopressors actually start to work. But if you're going to reach for a vasopressor, reach for norepinephrine. It's your tried and true. It's your friend. Use norepinephrine for these patients to help resuscitate them. And then lastly, and most importantly, get these patients to the ICU as quickly as possible. Get them the hell out of your emergency department.
Happy to have them. Bring them up.
Excellent. Just one last thing I want to add was that hydrocortisone 100 milligrams IV should be given before thyroid hormone to cover possible adrenal insufficiency. Ideally, you want to get that steroid in first before you even start the levothyroxine. All right. Fantastic. I think we summarized all the key points there just between the three of us. So I don't think there's any need to do any further summarizing. Thank you so much, Dr. Willis, and thank you so much, Dr. Lewis. You guys were just on fire. Like, that was just smooth and hot and just incredible. So I really appreciate that. I'm really looking forward to part 2 when we talk about when the thyroid goes through the roof.
So are we.
Looking forward to that too. Yep. Looking forward to that one too.
Excellent. So until next time, when it comes to decompensated hypothyroidism, catch it early, give steroids, give T4 early, rewarm gently, treat the trigger. If you miss it, the mortality rate is north of 40%. So keep the triad in mind, and you'll turn a potential ICU disaster into an ED save.